Good afternoon, everyone, and welcome. Thank you for joining us today. Today's session forms part of the INNEG webinar programme, I'm sure many of you have been on and you know, where we explore how expert evidence is used in complex claims, with today's webinar focused on neuro-oncology from the perspective of a neuroradiologist. Before I introduce to you today's speaker, I'd like to highlight INNEG's specialism in sourcing consultants within the imaging field. From neuroradiology to radiography, both adult and pediatric, we have experts on our panel who can assist. And if you'd like to see how many experts we have in each of the individual specialisms, you can search on our website, inneg.co.uk. But without further ado, it actually gives me a lot of pleasure to welcome today's speaker, Professor Sotirios Bisdas. Sotirios is a consultant neuroradiologist and expert witness specializing in both adult and pediatric neuroradiology, neuro-oncology, brain and spine injury, and advanced neuroimaging. But on a personal note, Professor Bisdas, Sotirios is someone who I have personally had the pleasure of working with over quite a number of years, probably 5 or 6 years now, and together I have seen him do a huge number of reports and consistently high feedback and praise from the solicitors who instruct him. And I don't lightly offer a recommendation of many of the experts we do, as that can on occasions come back to challenge you. But on this occasion, it really is deserved, and Sotirios is a fantastic expert witness and also clinician, and I'm sure you'll find out about that over the course of this session. Before we begin, I'd just like to advise you that we will be doing a Q&A function just after. So the Q&A function at the top or in the chat function, feel free as you go through the session to put in any questions that you have, and we will try to get to as many as we can at the end. In addition, all of the slides and the recording of this will be made available to you following the event in the next couple of days from our marketing team. But without further ado, please may I introduce you to Sotirios, and thank you very much for joining us today.
Thank you very much, Leo, for the kind introductory words. I'm very happy to deliver this presentation, and hopefully that will be a brilliant opportunity to show more the neuroradiologist's role. For some people, it's behind the scenes. In my opinion, is a frontline role in the treatment of patients with neuro-oncology. So a very short introduction and outline of my talk. What you will be seeing is imaging, of course, but this is not a radiology course. Here, the aim is helping you to read a brain tumor case and the way a court would do. So I have 6 learning objectives. The first is to familiarize yourself with what an MRI report should be and how it is actually in the real world. To introduce you to some concepts in neuro-oncology which are of paramount importance for looking at the images and judging about the treatment outcome. These are the progression, the pseudo-progression, the pseudo-response, and the radionecrosis. Then a very important objective is to set and tell what is the trial grade imaging or the optimal case imaging, and which is the real world district hospital imaging. And we will understand through this lens the modern neuro-oncology MDT and its role. And we will also touch base on the contemporary measurement tools that we have and change the standard of care. So the whole thing will be placed with a radiologist in the legal landscape in a central role. And at the end, I would also try to emphasize that, as I said, it's not a radiology training course. The examples that we will see are illustrative and not advisory. And very important, the even-handedness, so the content is drawn equally from claimant and defendant perspectives. So the first thing we need to talk about is the gap between what is imaging in a published paper in the textbook and what it looks like when it arrives in your bundle. We have here three numbers, which in my eyes or in neuroradiologist's eyes are quite shocking. The first is that only approximately a quarter of the centers in Europe apply structured response criteria for follow-up on brain tumors. So there is no standardization at all how they evaluate the tumor response to treatment. The second is that one quarter of them also uses kind of structure reporting template, which would help the expert understand what the radiologist saw, what he missed, and what it could be better. And at the end, 60% of the radiology reports are free text reports, is prose. And this makes things difficult to understand for an expert what actually the radiologist meant at that time, whether he has genuinely understood the problem and looked up for solutions for his clinicians. So the imaging we read in a textbook is not, as a rule, the imaging we will see in disclosure. And as experts and you as lawyers, they must address what was reasonable at the relevant date and place, and not what would have been ideal. Let's start now with a very basic slide, is how a brain tumor is read. I'm not talking about the imaging, the radiological features of brain tumor in the MRI, but how the tumor is classified radiologically, histologically, molecular, and then these actually parameters will be the ones which are crucial in the equation for the survival. Nowadays, or actually since 2021, the World Health Organization has changed the nomenclature for the tumor classification. In other words, the vocabulary has changed. A glioblastoma before 2021 is not the same glioblastoma we classify today. And this actually classification, the today's classification is more accurate, and it takes into account the histological and molecular genetic information that we missed in the past. However, we should keep in mind that the prognosis and the survival figures that are derived from the new classification are applicable in the older tumors as well, if we have information retrospectively about the tumor genetic makeup. So some figures, so in other words, figures from older literature, they cannot be used in an expert witness report to support findings about and conclusions about survival or projections about survival. So the prognosis and the quantum evidence should reflect the current classification and the current treatment standards. So very crucial questions now for the expert is whether a tumor has been classified under the new classification, the WHO 2021, whether we have information in order to subgroup it in smaller categories, which, however, have really paramount importance for the survival, and whether the current treatments, which are not always the standard chemotherapy or the first-line chemotherapy, they have been taken into account and have been actually considered in case or in a way to change the prognosis. So, as a neuroradiologist, I will first tell you what an MRI tells you and what it doesn't tell you. So when we have the modern MRI, and we see that through the lens of the new classification, the MRI can, like before, give the presence, the location, and the approximately lesion volume. Now, with the use of AI, we can give the exact lesion volume. We have information about the mass effect and the problems that the mass effect causes on this adjacent eloquent structures. And we have a very important baseline. And this baseline is the benchmark for the treatment response or the final outcome at the end. Still, MRI is not so accurate in order to classify the tumor according to its molecular features. This remains the domain of the biopsy, like before. And also, we cannot tell from a single or from two MRIs, successive MRIs, we cannot project backwards to tell where we had an onset of the disease. The onset of the disease will be dictated mostly by the clinical data. And then based on the MRI, we will classify, and this histology, we will classify the tumor, and then the neuro-oncologist will tell us about the figure, about the survival figures. So I think that is an important point because the defendants sometimes argue, if we had scanned earlier, we wouldn't have seen anything anyway. So it is something that the expert needs to engage with that explicitly and not dismiss it. And there are clear lines that should be articulated. Now, we know now what an MRI does and does not establish. However, the quality of the MRI is crucial. And the gap between the trial grade or the tertiary care imaging and the real world imaging is sometimes astonishing. The trial grade, or how it should be in an ideal way, an optimal way, would give a lot of information, a wealth of information, which is derived by standardized high-resolution protocols, by consistent sequences and measurements across the time points, and it is designed to work in a time-efficient manner. So I want to stress here that these protocols are not protocols which take hugely long times. These are protocols that can be used in the clinical routine. However, the real world is different, and we have significant variation between hospitals. The radiology departments do not optimize the imaging in order to provide accurate information or as accurate as possible. We may have missing sequences, inconsistent protocols across different time points. And of course, on top of that, we have, as I said before, the qualitative prose, the narrative, and less structured reporting to help us understanding what the neuroradiologist had in mind in the specific context of these clinical symptoms and whether he has spotted the problem. So in many times we have in the reports ambiguous expressions, and this doesn't help us at all. So in that case, the report may be misleading, and a competent clinician would have sought clarification. Or sometimes we see that the competent clinician over-relies on the report. This is an internal workflow issue in many hospitals. And in that case, it is difficult to assign a breach of duty to one or the other. And I think the breach in that case may be apportioned and not exclusively on the radiologist. When I get this bundle with this kind of imaging, I need to address very crucial questions. First of all, if the imaging was state-of-the-art, whether something has been missed or done in a suboptimal way. Then was the report reasonable? Was the reliance on it by the clinician also reasonable? And very important, has been an MDT review which has decided the further treatment based on this report and also the input from the clinical colleagues. Sometimes we need a clarification, or sometimes the report needs a clarification. And there are cases where the clarifications have been sought after by active contact with tertiary centers, but sometimes the clarifications or the have been missed or they haven't been pursued. So once I have the report and I try to understand the train of thought for the reporting radiologist and how this has impacted the outcome, I need here to understand the sequence of events and the sequence of time points. And this is something that you should keep in mind because things have changed a little bit the past years. When we want to understand whether a tumor treatment was effective or was according to the guidelines, we should judge the evolution of the tumor not compared to the preoperative MRI in terms of brain tumors or to the pre-intervention time point, but we should benchmark it against the post-interventional time point or post-surgery time point. If we have combined chemoradiation and surgery, then the best baseline now is not the diagnosis, the preoperative one, not even the postoperative one. The baseline now has become the post-radiotherapy MRI. And comparison against preoperative imaging only confuses because during the radiation therapy, we may have the phenomenon of pseudo-progression. So it is a transient progression, which will actually give back in the following weeks and will actually show us when we have down the line more time points if the treatment worked or not. So the pseudo-progression is something that as a concept is very important in neuroradiology. And I would take this opportunity today to introduce this concept to you in order to understand that the tumor during the treatment changes its features, gives the impression that there is progressive, but it is not. We have to wait after the treatment, after the chemoradiation, approximately 12 weeks, and we will see, at that point, we will see if the treatment worked or not. There is a similar concept of the pseudo-response that I mentioned before. The pseudo-response is when we treat the patient with immunotherapy. And the immunotherapy has some peculiar impact on the tumor. It turns off, in practical words, it turns off the vascularity, the blood supply. Once the blood supply in the tumor is turned off, the tumor starts shrinking and becoming necrotic. However, this is not always a successful treatment outcome. And again, we should wait and we should think about the phenomenon of the pseudo-response because before we conclude on the treatment outcome. Now I will move to the next domain, which is important when we look into the files of a brain tumor related breach of duty on the radiology side. It's about measurement. It might sound trivial, but measurement is still one of the pillars to judge about the treatment outcome. And measurement, unfortunately, is highly variable. Every radiologist measures the lesion in a different way. And these measurements are not at all reproducible across the different raters. Even two competent neuroradiologists can defensively disagree on measurements. So we need to understand that in that case, the court applies the Bolitho principle, because here we don't have a numerical majority test. The best way to create reproducible measurements is to do volumetry, to use specialized software in order to capture every corner, every edge of the tumor. And however, this is, as I said, reproducible, however, it's time consuming and it never happens in the clinical practice. So inter-observer variability in the measurement can inform in a wrong way the MDT and its bottom. Today, by using AI, we can overcome some hurdles in the measurement. And the studies, they have shown that 36% increase in the reliability can be achieved when we use AI. Also, the so-called DICE score is a score which shows how close to the gold standard, which is an experienced neuroradiologist, a deep learning AI algorithm can produce results. So, and 83 to 88% is a very high DICE score and essentially substantiates the use of AI in neuroradiology and in medico-legal work. It is not, however, very straightforward because the AI acceptance is not universal among radiologists. The standards and the guidelines requires a demonstrated AI awareness among neuroradiologists or radiologists, but unfortunately, only 1 out of 10 they have formal training. And of course, we have legal hurdles which are related to the product's liability and the standard of care when AI is involved and whether it should have been used or not. I think that it is a whole new chapter which warrants further discussion and investigation, because I think the question here, if the unused AI tool engages a volume question and the used AI tool engages a product's liability question, is a very obvious symmetry that needs to further to be investigated in the future. Having now all these tools, having also the timeline of the tumor evolution, we come to the MDT. The MDT is a pivotal concept. And the MDT is the venue and the group where the diagnosis is actually made and the treatment is suggested. And the standard of care should be understood in that context. Neuroradiologist, which is responsible for the imaging, the measurement, and the advanced techniques that will help for a more accurate tumor characterization, sits on one chair, and the rest of the chairs are shared with a neuropathologist, the nuclear medicine specialists where available and where needed, and the three colleagues which are mainly on the clinical side and are the neuro-oncologist, the neurosurgeon, and the radiation oncologist. Here, the MDT carries a significant legal aspect, because the modern oncology, the modern neuro-oncology MDTs, they treat the patient and the whole patient medical record as in a holistic way. And in that case, the standard of care, which are dictated by a reasonable MDT, is the one that can be best offered in the patient at a specific time. However, we need also to understand that how the MDT reached this decision. And we ideally you should have access to the MDT minutes and not only to the index report, because the MDT minutes will show us which was the weighting of the recommendations of each expert sitting around the table, and whether the neuroradiologist's recommendations or views were considered at an appropriate manner and weight. So we may have the case that an MDT was not convened, but in that case it should be. It should have taken place because it was reasonably indicated. That introduced a standard of care issue. And unfortunately, it is not a rare phenomenon, even in countries where the MDTs is actually mandated by the guidelines. So now, what does the neuroradiology actually bring in the MDT discussion? When we evaluate the neuroradiologist's role at the MDT, we should understand whether the imaging was really viewed in a full clinical context with information that might not have been available to the reporting radiologist at the previous time point. We should know whether there was a consistent comparison across serial scans, the way I showed you before, where the right baseline time point was chosen and was the benchmark for the comparisons in the future. We should understand whether there was a quantitative assessment of the tumor progression, identification of pseudo-progression versus recurrence, or radionecrosis. Radionecrosis is when we have necrotic or necrosis-induced changes due to excessive reaction of the brain tissue to the radiation treatment. And radionecrosis is not tumor recurrence. And the radionecrosis treatment is completely different than the treatment of a tumor recurrence. So recently I was involved in a medico-legal case where the neuroradiologist did not advise for further advanced imaging, which would be very useful in order to characterize the tumor and would shape the treatment selection. So in that case, taking this example, I would like again to highlight you that if the neuroradiologist sits at the MDT, he has an obligation to inform his colleagues about all available techniques that can be used in order to provide as accurate as possible recommendation for the patient. Now, why MDT is important? MDT is tangibly important because changes the patient treatment in 40% of the cases. Of course, this is an empirical impact, which I can share because it is also the way I have experienced it during the last 25 years that I'm part of MDTs. In that case, if we have an MDT change and a change in the MDT decision, the majority of this change is based on the neuroradiologist's evaluation. So the neuroradiologist should have secured time in order to review the imaging in the full clinical context, as I said before. Talking about advanced techniques, it's not only MRI, it's also PET. And of course, PET is still expensive for brain tumors because there are special tracers that are not broadly available. But equally to the PET, there are also MRI techniques like spectroscopy, which should be brought into the discussion by the neuroradiologist because they can significantly alter the outcome of the MDT. So in that case, I think it is important and it is probably very obvious that the radiologist MDT doesn't just polish the MDT minute. It frequently changes the treatment plan, so this contribution is material. And the RCR, the Royal College of Radiology, is very aware of this. And for the Royal College of Radiology, the high quality report is the first pillar, but the contemporary toolkit goes beyond that. So the RCR's professional standards is the identification and communication of relevant findings, the clear reporting, and also recommendations for imaging imaging or escalation of significant findings. Now, on top of that, on the right panel, I have put what has been available in tertiary practice and also increasingly in district settings, where the radiologist's role is enhanced. And this was the advanced volumetric measurement for measurements, the newer techniques, and the AI-assisted measurement and segmentation tools. These toolkits, they should not be, let's say, something which is on our wish list. They should be actually demanded from the MDT, from the clinical MDT partners, because they actually a very decisive role. And the key question now is whether these advanced tools that have been used in a reasonable way, and if not, where the liability sits. So, can we call it a duty to use reasonably available tools? So, I think before that, we need to understand that we have what is reasonably available, and that it is not every cutting-edge techniques. Tools that are reasonably available are the ones that at the specific date and place the neuroradiologist would have access to, or things that could have arranged by or through a tertiary referral, or just by picking up the phone and asking for advice. So the next question is how these tools and their use materially change the conclusion. Here we have to say that we have to understand whether the omission of using these tools left the conclusion meaningfully less reliable than it should have been. And the third thing that we need to consider is the MDT exposure to these tools. For example, what was put before the MDT and how the MDT actually reacted, or how the MDT took this information. For example, if we had a measurement which was unreliable, would this be considered, or the MDT should have asked for volumetric measurements which are reproducible? And does the MDT relied on obviously incomplete imaging information, or actually prompted for more information before it takes the decision? So now I will come back to the concepts of pseudo-progression and pseudo-response for a minute. The reason is that the measurements always do not reflect the truth. Again, I would like to familiarize you with common scenarios, which are the post-radiotherapy glioblastoma, the targeted therapy response patterns, or the post-stereotactic or gamma knife metastatic disease. These are scenarios where the measurement where the changes are, they have the changes, they have a pseudo character than I meant before. And worsening imaging does not always mean equal tumor progression or response. This is the domain where the neuroradiologist is necessary in order to introduce the concept of more exams, more advanced techniques, and hold a red flag or pull the red flag for the MDT. And usually I can tell you from my experience, when there is suspicion of pseudo-progression or pseudo-response, the MDT takes a step back, or the neuro-oncologist takes a step back, and the neuroradiologist now is the one who drives through its advice the MDT bottom and the MDT recommendations. So I will not give you more on this, because I just wanted to give you a high-level understanding of the pseudo-response or all these pseudo-conditions. Here is an example, and these are one of the few slides where we will look at the images, where actually we see a tumor which seemed to be, I will just use the so here we see an area where the tumor was originally localized, and it has very little contrast enhancement. If we use advanced techniques like perfusion MRI, you see that this little enhancement was not a sign of tumor response. It was a sign of pseudo-response because immunotherapy regimens were used. The perfusion MRI shows here that the posterior part of the tumor is well vascularized. So, and the MDT decision that relied on these images without the neuroradiologist raising the flag of pseudo-response is a wrong decision. Here, any further decision on the treatment should be seen through the prism of the advanced techniques or other additional measurements which show the extent of the remaining disease, and this would inform the next treatment. So, going back, one of the things that I come across when I'm invited to write a medico-legal report is about the growth rates. And growth rates or the back projection may be risky. What we can support as neuroradiologists is that in case of a low-grade glioma, a low-grade brain tumor, we have an approximate 3 millimeters per year annual growth rate. But this can be often exponential and not linear. The meningiomas, which are also low-grade tumors, they remain stable for years. And we have some growth risk tools available in literature if we want to do some back projections. Now, the real problem is with a glioblastoma. Glioblastoma is highly aggressive, and back projections beyond 6 to 12 months are rarely defensible. These glioblastomas, they can have a 50% growth within a month. So it is something very risky and I would say irresponsible to make back projections about that. Also, the brain metastasis, the way they grow, it depends very much on the therapy, on the systematic therapy that these patients received for the primary tumor, as well as on the existing treatment regimes, particularly the ones which involve gamma knife. Now, a very important message here is to understand the continuity between the low-grade brain tumors, gliomas, and the glioblastoma. The low-grade gliomas, they have, as I said, a very slow growth, but at some point we have the turning point, which is the so-called transformation. And particular gliomas with some particular mutations, they can transform into glioblastomas through this evolution in time. However, the timing of this transformation is unpredictable. We have some indirect signs in the imaging, for example, new enhancement or increased perfusion or rising metabolites on spectroscopy. But the time point of transformation is again very risky to predict. So, this is actually one of the last slides that I would like here to talk about the causation in the delayed diagnosis claims. The neuroradiologist can identify what was visible on imaging and assess whether findings have been reasonably identified, compare the serial imaging, and so on. This is actually a state-of-the-art neuroradiology input in the neuro-oncology patient. However, the neuroradiologist cannot state the exact date of the tumor onset, cannot determine the survival outcomes alone, and also cannot tell things that or resolve consent issues from imaging alone. Everything should be in the wider clinical context in order to determine any breach of duty for the neuroradiologist or the radiologist. Again, the prognosis and the survival is a moving target. The modern tumor prognosis is changing rapidly due to advances in imaging and molecular classification and treatment pathways. And the role here, in its role and importance in tumor claims is because historic survival figures can not longer reflect the current outcomes. So the prognosis should be always seen in the current tumor classification. And I mentioned before the WHO 2021, where imaging and the biopsy results play the central role. Now, in case we have a possible recurrence, the neuroradiologist should see the whole thing in the appropriate timeline, has to quantify the radiological change over time, choosing the right baseline. And in that case, we'll have an accurate and objective treatment response versus progression or versus different pseudo phenomena. Now, when we have all this as a foundation, I would like to spend a few minutes on trying to understand the apportionment of injury. The doctrine here has not changed. We have the same inputs. For example, the Gregg versus Scott remains binding, where pre-negligent survival was below 50%. But here, the modern survival data play a key role. And the key question now becomes about the degree of lost opportunity and not the absolute survival probability. And so the apportionment may be appropriate where delay materially worsened an already serious condition. In the apportionment, the neuroradiologist's role is to quantify what changed during this delay window. And we have the tools that I mentioned before about the volumetric, about all the imaging features that are visible, and along with that, we have any advanced features. So in that case, the neuroradiologist quantifies the imaging features. The neuro-oncologist translates these into survival and functional outcome impact, and the apportionment is built on this division of labor. When it is about now radiology negligence. We have to understand that the question is not simply whether the scan was wrong, but it was about the interpretation, which should be taken at that time. Well, here we have also the volambolito principle, was the interpretation supported by a responsible and logical body of opinion. That in diagnostic cases, the court may choose between competent expert reviews, and the reasoning still has to withstand scrutiny. So in that case, I would bring that about the radiological report in the appropriate treatment window and treatment framing. So the radiologist has a duty to judge and have a proper reasoning in his report. And then this report in the MDT context will dictate the treatment. I would like here to pose some questions here to the audience, where actually the treatments is not, that there are many treatments that I mentioned before. However, many of these treatments are not available at the particular place or the particular hospital. And it is here, in my opinion, a very important thing to understand whether there is breach of duty when a treatment was a reasonable alternative but was not available, and also whether the patient should have been informed about the available treatment, or the radiologist, along with the other MDT members, would have deemed that this alternative treatment should not have been mentioned because it was not applicable to the patient. So with that open question, I finished the main body of the presentation. I have some cases to go through. These are cases which, some of them are real, some of them are fictional. But through a couple of scenarios, I would try to link what I just mentioned to the real world. So the first is the case of a pseudo-progression and the treatment withdrawal. So the patient in this scenario had a glioblastoma, which underwent surgery followed by chemoradiation. The early post-treatment MRI was interpreted as progression because the wrong baseline was chosen and this tumor appeared to grow. And the adjuvant treatment was stopped. This patient would qualify probably for a second-line treatment, which carries more risk than the first-line treatment. So the key questions now, so we have an alleged loss of survival opportunity following the premature treatment withdrawal and selection of a less effective treatment. So the key questions now for the neuroradiologist role or for the radiologist role was if the imaging has been interpreted as pseudo-progression, and whether this information or this suspicion of pseudo-progression was communicated to the MDT, and whether the MDT also put the right value on it. So the clinical reality is, as I said before, that early post-treatment imaging changes can imitate progression. So the neuroradiologist should wait, and the MDT in total, the MDT should actually issue a votum to wait for another 3 to 4 months before definitive change of treatment is initiated due to a poor outcome. So pseudo-progression should not inform wrong treatment change. A second case is about actually the so-called the missed lesion archetype. So we have a 42-year-old patient with progressive diplopia. The MRI was reported as normal, and the symptoms were treated as presumed microvascular nerve palsy. Diplopia is a very common finding, is a very common symptom, but I would, as an experienced neuroradiologist, I wouldn't actually pay less attention to that and treat it like a common headache problem. There are fine problems, fine causes that can cause diplopia. And I mean fine because they are very small and they are hard to find in the MRI. So at last, we saw a retrospective review in this patient confirmed that the lesion, which was visible on the original MRI, was the culprit for this diplopia. And the key question here is whether the retrospectively visible lesion is the same or not with a negligently missed. And was in this case the lesion reasonably identifiable at that time within the quality and context of the original scan. There are many parameters here apart from the radiologist that play a role, and one of these is the quality of the scans. So as I said before, in an ideal world or in a, let's say, tertiary center, the imaging is sufficient in order to detect small lesions. However, this is not the case in district centers or in the periphery. Assuming that the lesion was there and was identifiable, I think that perceptual misses occur even within competent practice, and the relevant question here is whether a reasonable neuroradiologist. In that case, in order to address this question, I think the independent retrospective review should be blinded to the later imaging in order to reduce the hindsight bias. But I think that some instructing solicitors disclose the eventual diagnosis upfront. This is something that it has both pros and cons, but in my opinion, the most important, or maybe the one that works most, is when the expert is blinded to any lesion, missed lesion, but it's full aware of the clinical context. Another case with a misclassification of a temporal tumor, in other words, a tumor in the temporal lobe, is in a case with a seizure. So usually seizures are manifested in elderly people or in adults, are manifestations of an underlying tumor. And in that case, the MRI identified the lesion as a probably benign cyst and no follow-up recommended. 2 years later, the repeat imaging shows progression to an astrocytoma, to a low-grade tumor. And the patient now has developed cognitive and neurological symptoms, and definitely the treatment of a tumor is much different than the management of a cyst, which is completely indolent. So the key question is whether this lesion was reasonably misclassified, or the imaging should have triggered subspecialty neuroradiology review. Either the radiologist, for example, in this district center should have referred the patient to the Neuro-Oncology center nearby, or should have called the neuroradiologist to ask for his opinion. As I mentioned before, the next or the third scenario or the third option would be to proceed with advanced techniques that would show that this is not a cyst, but a tumor. So the temporal lesions now, the facet is that the temporal lesions presenting with seizure activity, mostly in adults, require specialist neuroradiology assessment and follow-up imaging. And here, the relevant question is, as I said, whether the escalation or the further investigation was reasonably required. And in most of the cases, it is something which is really it's really state of the art and is along the recommendations. However, the final decision is made by the MDT. So if we now examining the radiologist role, we should have access to the minutes of the MDT to see whether this was actively suggested by the neuroradiologist or the radiologist, and whether it was correctly perceived by the other MDT members. So the final case, because we are running out of time, is about a fictional composite, which, however, is the real world case in many times, and it is about the suboptimal imaging protocol. In this scenario, the 39-year-old presented with cognitive symptoms, and in case of cognitive symptoms, headaches, very sometimes unspecific, not very clear neurological symptoms, there is a tendency, or maybe sometimes I can say this is the rule in the district hospitals, to make a very abbreviated, a limited imaging protocol, which is also many times seen as, or it's not a red flag case, or it's a normal routine case, and there are perceptual errors when the radiologists read these cases, and they see that as a very trivial case, and a very and actually they don't give a lot of time for reporting everything, so reported hastily. I don't want to expand more on that, but what is here the important message is that we miss findings. We are missing findings which are retrospectively easily seen. So we have now a lot of times the question whether this was readily seen, should be readily spotted by the neuroradiologist or the radiologist, or was an inherent drawback and weakness of the imaging protocol that could not reveal that in the first place. So this is the clinical reality that I mentioned. So we don't have good imaging protocols in district hospitals in the periphery. The protocols are not symptoms shape-driven constructed. So it is a generic protocol that covers any neurological disease. And I raise here the question to the audience, whether it is breach of duty for the radiology department not to use specific protocols for specific clinical questions, and not to invest in refining these protocols, making them fit for the clinical question. So as a key expert here, we have to divide our work into and separate the issues. So whether the imaging protocol was suboptimal, was the right protocol for the work, whether the scan interpretation was suboptimal and was too quick and very superficial. And finally, we need to see whether in these narrative reviews, in the narrative reports, which is not state of the art, and I don't agree with them, with ambiguous expressions, there was an escalation pathway that was not considered. And this escalation pathway for the specialist could have saved a lot of time and would have materially changed the final outcome. So we are already now past the hour, and I would be happy to take any questions from the audience.
Hi, Sotirios. First of all, thank you very much for that. That was incredibly interesting, and I am left curious as to know what exactly are on your next 10 slides, because the first the first number was so interesting. But just before we jump to the Q&A, I just want to briefly highlight for our viewers that next week, Tuesday the 16th, we're hosting our next webinar session on breast cancer claims. And we have Dr. Vasilios Angelis, who's a consultant medical oncologist, a specialist within the breast cancer world, coming and speaking to us on that. So if you're not already registered, please do jump in. And with that, I just want to come back to this webinar. If you've got any questions, please pop them now in the Q&A. I appreciate there are a few more slides which we haven't been able to get through. But as questions might be coming in, there were a couple which immediately jumped across to me as I was watching that. You mentioned a little earlier on in your slides that, well, you asked the question, so to speak, should the consultant, should the clinician, are they required to inform the patient of a treatment that might be reasonable for them to have, but isn't available within that particular hospital or trust? And I wanted to ask you that question. Should the neuroradiologist have informed the patient of a treatment that isn't available or they cannot provide, or are they not required to do so?
Well, in my opinion, we have a duty to inform the patient because we are not acting behind the scenes. We are part of the treating team. We do the diagnosis and then we follow up the patient. So for treatments that are based on radiology, based on imaging, and when I put a little bit about the background, when I put this slide, I didn't have in mind something which is the standard treatment or the new pharmacological treatment. I had something very specific in mind, which are the imaging guided treatments. For example, in brain tumors, we have laser ablation, which is image-guided laser ablation, and it is done by the neuroradiologist in collaboration with a neurosurgeon. So these are the newest developments in the field, and they are available and they are accessible. So I think that the neuroradiologist has the duty to inform the patient. So the neuroradiologist, as I said, should be on the front line, should be the one who will have also consultations with the patient. And of course, it is not meant to act independently and not in accordance with the NDT, but it has the duty to inform. Now, the MDT maybe will be the body which will decide whether this treatment is actually suitable for the patient. But in case that this is suitable, in my opinion, the MDT should also issue a formal votum asking the patient or referring the patient to another tertiary center where this treatment can be done.
Okay, that very much makes sense. The job of the neuroradiologist is to give all of the possible treatment options which are reasonable, and if they're not available in that hospital, to signpost the patient to potentially approach one of the other trusts with which they can arguably obtain that particular treatment. Thank you. There's a question from Sophia.
Maybe just expand a little bit. Maybe it's also here for the audience. It's also food for thought or questions to ask whether or to which extent actually the MDT today is informing the patient about the ongoing clinical trials, which are testing new drugs, prototypes that carry a significant advantage or merit to be trialed or to be taken by the patient.
Thank you. We have a follow-on question from Sophia Azam, who has asked, is the choice of imaging protocol, the choice of imaging protocol used, is it a decision for the neuroradiologist or would it be that of the referring clinician?
It is all purely of the neuroradiologist. Given that the referring clinician has described as best as it can be the clinical picture and the clinical symptoms and the background. Once these are articulated clearly, then the neuroradiologist would decide which is the optimal protocol. However, this does not happen. The chain has many weak parts here. First of all, the clinician has described the whole clinical problem in 5 words. And then we have the vetting problem. And the vetting problem is that the neuroradiologist has not actively participated into the protocol selection. And this is done by radiographer or by an by administrative office members. So this is the source of many problems and the source of many medical errors.
Thank you. And just lastly, myself, I was also thinking, you've commented on the importance of an MDT, and for a solicitor to be able to review the MDT notes, or the clinician, should I say, the solicitor and the expert witness reviewing the MDT notes. I appreciate that not all clinicians and trusts include MDT notes as standard. And I wanted to ask what your suggestions might be if they aren't forthcoming, or it's perhaps responded from the trust that they haven't been stored. Surely you must have seen many cases where MDT notes aren't available, and how do you deal with that given that circumstance?
Yes, I have seen, and recently I had a case where only the MDT vote was available, and not even the MDT members were listed who participated in this discussion. In that case, I don't think that we should actually assign the breach of duty clearly to any of the MDT members, since there is we are lacking evidence. Who suggested? Who thought that it is correct? Who thought that it was wrong? Who were the people who disagreed, agreed, and so on? Of course, it is a majority votum at the end. It's not a unanimous votum. So lacking MDT minutes or details about how this decision was made makes things very difficult. And I don't think it is an easy case at all. So we cannot really point to specific persons for medical malpractice.
Thank you very much. There doesn't seem to be any further questions right now. So all that leaves me to do today is to thank you very much, Sotirios, for your time. Thank you for spending it introducing us and giving us a lot of high-level detail about neuro-oncological matters.